Thank you very much, Mr. Nefat, for this introduction. Today we're going to talk about pacemaker troubleshooting, and we're going to present this lecture as multiple case scenarios and tracing how should we deal with these cases. First case, this is a rhythm strip from a patient who implanted a single chamber pacemaker. And we can notice here that there is a pacing spikes at a fixed rate, which is about 60 beat per minute. Whenever the intrinsic beat occur, it doesn't reset the timing. Also, when the pacing spike occurs in a baseline, there is no catch. So this is a typical ECG of a pacemaker that have a failure in capture and under sensing of the ventricular lead.
Okay, Dr. Rosas, you are going to give some examples and then we'll ask the audience to answer, yes?
Okay, no problem. From the next case, I can give the slide that anyone who likes to share it.
Because I can see them in the chart, in the chat group. They are answering. Dr. Amr answered correctly. So give them just 1 second to think, and then we will give the answer. Okay.
Okay. So this patient who has a single chamber pacemaker programmed to a base rate of 60 beat per minute. However, we notice that there's a pacing at a rate lower than the lower rate interval. The lower rate interval should be 1,000. Here, we notice that the pacing comes after 1,200 milliseconds. So why the rate of pacing varies and becomes lower than the lower rate interval?
Please answer in the chat, or anyone who wants to answer loud, no problem. Dr. Abdulrahman Ajalin. Dr. Abdulrahman. Okay, go ahead with the answer.
Okay, this is what we call it. This is a hysteresis. As you can see in this diagram, when the hysteresis is off, once the rate, the blue line is the tourism and the red line resembles the pacing rhythm. When we go to the lower rate interval, we become based when off. However, once hysteresis is on, it allows to search for a spontaneous rhythm till the hysteresis rate. However, once the rate is reached, pacing at the lower rate interval starts again, and searching is started again once spontaneous rhythm is detected. Sandroot devices and Abbott devices, it can allow for pacing at a programmable cycles rate before turning again to the lower rate interval. So this is a well-functioning pacemaker with hysteresis turned on. This is a dual chamber pacemaker implanted for a sex sinus syndrome, and we are testing for the atrial threshold. We are testing in AI mode.
Dr. Jihad Jamal.
What is the threshold of the atrium? Here, this atrial pacing, and here are the values: 1 volt, then 9, then 8, 0.8, then 7. What is the atrial threshold?
They are answering. Some said 0.9. دكتورة إيمان سعيد.
Okay.
1 millivolt. دكتورة عمرو جمال. لا مش قوي يا عمرو يعني.
The clue here is to look at both the channels of the EGM, the atrial channel and the RV and the ventricular EGM. As long as there is a conduction, as the patient has only sick sinus syndrome, and there is conduction in the RV and a spike on the RV channel. Once basing occurs here, and it doesn't capture no activity, no activation of the ventricle occur on the RV channel. So actually the threshold is 1 volt, not and here the morphology of the EGM didn't help us a lot in evaluation of the. However, the conduction and evaluation of the RV channel helped us more. So it's important to examine both the channels, and this helps us in the evaluation threshold as long as there is a normal conduction. Here we go for another case. This is a Holter recording of a patient who has a dual chamber pacemaker implanted. And we notice that the AV interval is variable. Here it's long here, then it's short. Is it a dysfunction in the pacemaker function?
Dr. Amr, can you answer? Be brave, guys. Open your microphone, Amr. Amr Jamal. Ta. Answer انت يا رصاصي.
Okay. This is a dual chamber pacemaker. Okay. Had intermittent heart block. We notice here that this is A-sensing and V-basing and PR and R interval. And this is the case as long as there is here. So this is likely the normal sensitivity interval. Here, the intrinsic rhythm is apparent but at a long PR interval. And here, the PR interval is still long by ventricular pacing. This is an algorithm called AV hysteresis, which is an algorithm used to minimize the unnecessary ventricular in case of intermittent AV block. The algorithm acts by prolonging the AV interval, and once a sensed ventricular activity, the AV interval is programmed at the higher value, and all these values are programmable. Once there is no conduction, V-basing occurs for some beats, then it shortens and returns to the sensed AV interval. And once spontaneous ventricular activity is sensed again, the AV interval is prolonged to the new value. Is it clear?
Is this search AV hysteresis?
Yes, this is electronic and AV and AV hysteresis, I think in Boston or Bytronic, and called I think it's called ventricular intrinsic preference in St. John's.
Yes, called VIP.
Yes, exactly. So this one is easy. This is an interrogation of a patient who planted, and here when this is the atrial channel, and here's the ventricular channel. To make it easy, we the upper rate and the upper rate is
Upper tracking rate.
120, and the atrial rate here 140. So what does this interrogation show? I can't make it easier. Any answers?
جاوب انت يا استاذ.
Okay. VA followed by VV. The AV interval here, you can appreciate that it's about half square. Here, it's about big square. Here, it's big square and one small square. So the AV interval is gradually prolonged. This is A not followed by V. And the A, again, followed by a short AV interval, and the AV interval is gradually prolonged till the A is not E. This is called the upper rate behavior or pacemaker wing path, and it occurs as follows. Once the atrial rate exceeds the upper rate limit, the AV interval is gradually prolonged. VA occurs during the B valve, so it's not censored. It's done again. This prevents occurrence of sudden 2-to-1 block when the patient exerts exercise, so that the heart rate doesn't fall suddenly. Most importantly, the upper rate behavior occurs until the atrial, the total atrial refractory period. As once the atrial rate is higher than the total atrial refractory period, 2-to-1 conduction occurs immediately. So this is an ECG from a patient with a dual chamber pacemaker, and we want an explanation for each spike of these. And I need a volunteer.
دكتورة إيمان سمير. يلا إيمان. The interaction is of great importance that we feel how you think and we know how you think. يلا إيمان. إيمان سعيد.
Okay, sorry, doctor. First spike A-sense V base.
Yes.
Okay.
A-sense V base.
Yes.
Then A base V base.
Excellent.
Yes.
The first one, null sense of atrium, and
Excellent.
and there is a fusion between the spike and the normal normal beat. So spike come after the within the QRS of the normal beat.
So this is a V basing spike, and this is an atrial basing spike, right?
Atrial basing spike come after the small sense of atrial beat.
It came after under sensing of the atrium, so it gave an atrial basing spike, which when function capture occur. But why did the V basing comes early here? You notice that the base AV interval here is about 200 milliseconds. Why is it coming here very early?
A ventricular safety basing.
Excellent. This is ventricular. The atrial basing occur, and incidentally, an intrinsic ventricular sensing occur. So to prevent ventricular safety pacing and PV pacing is done. However, no capture occurs as the ventricle is already depolarized, and this.
طب لا ارجع please go back رصاصي.
Okay.
So the problem here is the P wave was not sensed. How can you solve this problem?
We can make it more sensitive.
Yes.
So we can program it to be a higher sensitivity or reducing the value of the sensitivity, making it
So
more
you want first
sensitive.
to measure how much is the P wave sensed by the device in order to go lower and lower. Is there a difference between sensitivity of unipolar and bipolar in any machine in the atrium?
Yes.
Sometimes you can go down in bipolar to like 0.3, but in unipolar you cannot go down except to 0.5. So this is the difference in going down with the value of the sensitivity in order to make the atrial channel more sensitive. So you play with the unipolar and then with the bipolar, you measure the P wave sensitivity in unipolar and in bipolar mode, and then you decide what to do in order to avoid this. Okay, well, next example.
Okay. This was noticed during atrial threshold testing. This tachycardia occurred. We need a volunteer. What is this tachycardia?
Amr Gamal, open your microphone and answer. Say anything. We are accepting anything. Please. Please. From Bitar, Muhammad Bitar, please. Open your microphone, Bitar. Iman Saeed.
I think Dr. Mervat, when you paste the atrium and sense the atrium and the ventricle channel, and the BMT will occur. So you should be to increase the PVAR, I think.
Okay.
Why did it occur here? What happened? What's wrong? Yeah, your answer is we're doing.
Your answer is correct, but how can you explain it?
Here, atrial pacing.
أنت explain it. Thank you, Dr. Bitar. Where are you from, Dr. Bitar?
From Jordan.
When?
From Jordan.
Jordan. Okay, thank you. Explain it, Basasi, please.
Okay. As we said before, when there is an intrinsic conduction, we should notice both the channels. Okay, so there's here an atrial pacing and followed by ventricular sensing. Here, atrial pacing, notice the ECG there, hum, which is the B wave, followed by ventricular sensing. Here's atrial pacing, followed by ventricular sensing. We are testing in a DD atrial pacing, followed by ventricular sensing. Here, atrial pacing, there is no P wave, and so it didn't capture the atrium. So atrium is more. Followed by ventricular pacing at this long AV interval, and there is a retrograde conduction. Since as BC here means the device considered a PEC, retrograde conduction, which starts the BMT. What happened here is that the atrium didn't capture the ventricle, and the V pacing started a retrograde conduction. And here the different etiologies and the mechanism by which the BMT is initiated. And the most important thing is that there is the atrium is not depolarized. So it can be triggered by ventricular extrasystole here, a PVC, then a retrograde conduction. The atrium is not depolarized, and censored and BMT start. Or maybe initiated by atrial loss of capture. Here, atrial depolarization, no P wave, then V basing, then retrograde conduction, as the atrium is not depolarized, and an retrograde B wave is noticed and starts BMT. Or atrial oversensing, which starts a sensed AV interval and then followed by ventricular basing, and atrium also is not depolarized. Also, an atrial extrasystoles at the upper rate interval may be conducted at a long AV interval and followed by B wave. Also, if there is intermittent loss of atrial sensing, as the previous example, if there is no conduction, the atrial basing spike here delivered after unseen B wave. So the atrium actually is not captured by. So there is a lot of time to allow for recovery of the atrium, and retrograde conduction occurs and the BMT starts. So to overcome, as Dr. Amir said, we can prolong the PVAR, also adjust the sensitivity levels if the by undersensing of the retrograde B wave, means that we make it less sensitive. Also, you should avoid programming a long AV interval in patient with AV block, as this can initiate BMT. If you programmed it a very long, you give the atrium the repolarized and allow for a retrograde conduction.
لو سمحت يا دكتور،
اتفضل.
كم ال AV interval كم معانا ممكن مدة نقدر نزيدها أكتر إشي؟
Yeah, actually, I don't have exact number, but if you notice that when you are if you are programming a long AV interval intrinsic conduction and you notice BMT, and there is no other explanation for the and there is retrograde conduction during the normal essence, ventricular pacing should shorten the AV interval. Okay, this is another case. A female implanted adult chamber pacemakers, and she complains of. This is very common and very nice. What's seen here?
دكتورة إيمان. دكتور.
This is the ventricular channel. Here, V means pacing. Okay.
دكتورة إيمان بتقول لك mal sensing ratification. ما أعرفش إيه ratification. I don't know what is ratification يا إيمان. We are asking the patient to do hand pushing each other. Why? Because the patient is saying that she has dizziness. So while we are asking the patient to do this maneuver, we are looking at the interrogation of the device. So if you look here, the device has been sensing some artifact, as Dr. Iman said, and is inhibited because the device thinks that this is the intrinsic rhythm of the patient. So this is the oversensing of my potential from the movement of this patient. So how can you overcome this problem, Sasi, by programming?
First, you should evaluate sensing polarity. Here, the sensing polarity was was unipolar, so we program it to bipolar, and the problem is solved. And another thing is if if the problem is spectral my potential, it won't bipolar programming. However, if it's a matter of noise in the lead, we should consider evaluation of the integrity of the lead and program if the patient is pacemaker dependent, and we may consider replacement of the lead with another one. Also, we can try programming it to less sensitive value.
Yeah.
Less sensitive value. So this is another example of the problem is noise. And
So
it
it's
is
lead
actually
problem.
exactly, it's most likely it's a lead problem. Here also, if you are looking at the ECG, this is the atrial channel. Here, this is the ventricular channel. There's a noise that occurs sporadically in the ventricular sensing channel, and there is no ventricular activity ECG. So there is also oversensing in this patient. Here it's V sensing, no depolarization. And this also is a lead problem. Here also, this is the same patient with intermittent loss of ventricular capture, and the artifact is still present. Okay. So we go for another type of problems, and while we are programming, this patient has this rapid heart, this atrial high rate episode. What does this interrogation show? Any volunteer?
دكتور عمر ندى، انت فاتح الميكروفون اهو.
Can you hear me? Can you hear me? Can you hear me?
We hear you well. Answer this question. What do you see
Hello?
in this? شايفينك يا عمر. سامعينك.
Can you hear me?
Yes, we do. خلاص. جاوب يا إرصاصي. This is waste of time.
Okay.
Dr. Didier is answering this very well. Dr. Didier?
Okay. This is atrial.
كمل يا إرصاصي. We will not finish by this.
Okay, this actually an atrial fluctuation from the atrial channel, and here the atrial flutter is being tracked a sense, and the one beat is the other is atrial sensing followed by air reflex. So this one of them is tracked and the other is getting in the post-ventricular atrial refractory period. So this is a flutter which is being tracked. case, the mood switch was intentionally turned off to record this tracing, actually this tracing from the EHRA POC, and the mood switch is turned on. The mood switch is programmable, and it allows and you can program a certain rate threshold. The tracking mode is turned into a non-tracking mode like VDI or DDI. And here it's turned into a non-tracking mode, and spontaneous conduction is occurring now. Here is another example of mood switch. This is actually atrial fibrillation. As we can notice, multiple and variable cycle lengths on the atrial channel, and here basing at certain rate. No tracking here. This is another type of episode which is recorded, and anyone likes to volunteer and answer this interrogation.
Dr. Didier, can you answer this? Didier? Answer, Ahmed.
Okay. Here we can notice the atrial EGM shows two different deflections. Sharp and preceding the V, and the other is almost simultaneous with the V. Always simultaneous with the V. And the interval between these and this is not fixed and is not. This is always consistent and always related to the V. So this is actually R wave oversensing on the lead, which is called far field R wave oversensing. Here's the factors which favor the R wave oversensing, like unipolar programming lead, and during implantation, when you place the atrial lead in close proximity to the ventricle, and when you are making the atrial lead very sensitive and programming high sensitivity, and when you program a very short post-ventricular atrial flanking. So the clue to overcome this is to prolong the post-ventricular atrial flanking, usually programmed from 150 milliseconds to 180 milliseconds. This is a more difficult interrogation. This is a patient who had a dual chamber pacemaker implanted for intermittent heart block. And we could notice here that there is actually two pacing spikes here. And this is the atrial channel. You can notice that there is sync here and async here. What is the explanation for this? Or what's the differential diagnosis for such thing when you see this?
Please answer in the chat room. Dr. Iman, you were answering very well. Dr. Didier, Dr. Amr Gamal.
It's look like the atrial.
Okay.
It's look
Yes.
like the atrial lead oversensing the ventricular, or the atrial lead dislodge and become in the ventricle. So it's sensing the ventricular.
Excellent, excellent. The is actually sensing the ventricular, the ventricle, And here, when we reach the lower rate interval, actually the H is done and followed by, and actually it captures the ventricle. Here the morphology is different from here. Some sort of fusion beat occur. And this is a ventricular safety pacing actually. Clue that the atrium is actually sensing the ventricle and it captures the ventricle. So it's actually in the ventricle. And here is a pseudo-fusion beat. The basing spike is before the QRS complex. However, it is of the, there is no change in the. Here is the X-ray. Actually, you can appreciate that the atrial lead is displaced with the ventricular lead. Differential diagnosis that should be kept in mind, especially if the patient has just implanted the pacemaker, is the AV switch on the hip. And this is the typical ECG of AV switch. What we can notice here that is capturing the ventricle, and along AV time, then ventricular pacing. Actually, because the ventricular lead is placed in the atrial port in the header, and the ventricular lead is placed in the atrial lead in the header. And as the rate of the pacing is higher than the sinus rate and the atrial rate and rate and the ventricular and the ventricular يعني as long as the pacing rate is higher than the sinus rate, the ventricle is captured. What happens here is that the patient has tachycardia. So actually the ventricular lead, the second one, which is senses that as V sensing, V sensing, and V sensing, and V sensing, and V sensing, like VT. Is it clear or not?
Not clear.
Okay. Okay. This is for the device is atrial based by V basing, A basing, V basing.
But A pacing, because the atrial lead is in the ventricular port, it is delivering the impulse into the ventricle. Yes. لا.
Yeah,
The ventricular port is in the atrial.
This actually, there is no impulse has reached the atrial lead, which is actually the ventricular lead. So it's
ventricular lead is in the atrial port. So it did not sense the atrium, so it paces, and when it paces, it gives the ventricular complex, QRS complex. And
there
then
is no conduction, no retrograde conduction here. So the
second spike is the atrial spike, because this is the lead which is placed into the ventricular port.
Exactly. Exactly.
What happens here is that the sensing of the ventricular lead, which is placed in the atrial port, has sensed the P wave. It has sensed the P wave as if it is ventricular, because the amplitude has been sensed. So the pacemaker thinks, okay, this is higher than me, I'm not going to fire. But because it is firing the ventricle, it stopped firing, so the patient had this asystole. This is a very, very common question in the EHRA exam.
Exactly. So this is an important thing. that we should look for after implanting a dual chamber pacemaker, as it can lead to a disaster as happening here. As history. The device thinks that this is like a VT.
Yeah.
Or an accelerated ventricular rhythm.
Yeah.
Exactly.
You know why it started not, it was starting good? Because it could not sense the small P wave before the spike.
Exactly.
Yeah.
Exactly.
So how to solve this problem? First, if you are in the emergency room and you have the programmer, you program it to DOO mode or AI mode. AI mode is going to pace the ventricle.
Exactly. Because AI is VVI.
AI mode, because this is the ventricular lead, is in the atrial chamber. Or DOO mode, because both will be spaced, so no problem. But AI mode is good, or AOO mode is good. Then you have to go to the cath lab and open the wound and change the lead. The atrial lead should be in the atrial port and the ventricular lead should go back to it. I found this twice in my life and I did it once. But I discovered inside the cath lab.
Alhamdulillah.
Alhamdulillah. Okay? Yeah.
Another solution is to place a magnet. If you don't have a programmer available, immediately just place a magnet immediately, of course. So this is another patient with an atrial lead dislodged in the ventricle, and you can notice here that the A and V are
simultaneous.
You should have a clear ECG, as this may be actually a junctional rhythm, and you can only differentiate this from testing. Okay?
Yes.
And so this is another differential diagnosis. So this is a problem, but it's very important to know, and very important to identify, because it's actually fatal. So this is a patient with a dual chamber pacemaker, and here we start testing the atrium in DDD mode. What's happening then? As I said, this is almost historical now, rarely to be encountered.
دكتورة إيمان؟ دكتور عمر ندى؟ جاوب يا أستاذ خالص.
Here the B refers to atrial sensing, and the A refers to pacing. Here we notice that once we are pacing, there is R in the V channel.
Without QRS complex.
Without QRS complex. So this is crosstalk. This is actually the crosstalk. When
maybe you were testing at very high amplitude, so the ventricular chamber thought that this is the ventricular activity and it was inhibited. R means sensing the ventricle. This might be serine, because serine is the one who gives A for atrial pacing, P for P wave, R for sensed R wave, and مش عارف بقى التاني بيس V for ventricular pace. So this is very dangerous. Sometimes some engineers did this mistake maybe throughout my life, maybe 3-4 times. When they go to test the patient complete heart block and test for atrial pacing threshold, they go to AI mode, and this stops ventricular activity, and the patient would scream from headache, from stoppage of pacing, and would say, "Get this man away from me! Take this man away from me!" Yes.
So very dangerous. And here, as we this is the explanation.
ممكن تعيدها يا دكتور؟
So this crosstalk, the ventricular sensing the atrial pacing.
Spike.
Okay. So it reacts as V sensing. Here you can notice that there is no depolarization on the ventricular EGM. The ventricular EGM is just sensing here that the atrial pacing, and there is asystole in the ventricular asystole of the ventricle. Here just atrial pacing, atrial pacing, atrial pacing. While during the atrial sensing, there is no such problem. So this is the definition of AV crosstalk, that the ventricle senses the atrial pacing.
Interrogation during testing is very important. And in some machines, you have to choose dual EGM so that you can see the atrial EGM, شاور عليها رصاصي, and the ventricular EGM, the one under. In the ventricular EGM, you can see the spike, appreciate the first 3 beats, first. This is spike and QRS complex, spike, QRS complex, spike, QRS complex, and then nothing. What is this nothing? There is a far field atrial spike, the small one in the ventricular chamber, which gives it a wrong value, as if this is a ventricular activity. This is why crosstalk is of dangers, because one chamber can give orders to the other chamber false that there is activity, and this makes the patient go into syncope, may be arrested. Hey, come here, Sus.
This is a difficult question, actually. This is a 7-year-old female with chronic atrial fibrillation and single chamber pacemaker. She's programmed to a VVI at 60 beats per minute. Actually, you can appreciate her pacing of 72%. Here's the rate histogram. And here's the interrogation. Actually, there is pacing at higher than the lower rate. There is sensing, but here's pacing at a rate higher than the lower.
This is a difficult question. You have to understand that some pacemakers have functions you don't know. Sometimes the engineer himself does not know.
Exactly.
قال حلها بقى عشان ما حدش يعرف.
This is called the rate smoothing or regularizing algorithm. In a patient with irregular heart rate and like atrial fibrillation, the pacemaker to pace at a higher rate and make the rhythm regular as much as the pacemaker can. So it paces at a higher rate to keep the rhythm somewhat regular. It's not very regular, but it's not very irregular. So this is a feature rate smoothing algorithm. And this is the differential diagnosis of pacing at a higher rate than the programmed rate. When you should always think of all of these. First, the rate smoothing and rate regularizing algorithm, and this feature is programmable actually. Second, response, which is programmed in Medtronic devices in cardio inhibitory syncope. When a sudden drop of a certain volume of beats occurs suddenly, pacing at a higher rate, which is also care for an intervention duration, usually pacing at a DDD mode at a rate of 100 for 2 minutes. Also, some algorithms to prevent AF, which tend to perform atrial pacing at a rate higher than the intrinsic rhythm to reduce incidence of AF. However, studies found that This is actually not effective. Also, when you program auto capture, you may accidentally incidentally perform ECG during auto capture testing. So you detect rate higher than the lower rate which is programmed. Or when you are turning the sensor on and you are programming it actually very sensitive, or programming the threshold of intervention at a very low level. Or when actually a tachycardia or atrial high rate or induced loop tachycardia occur. Always remember that exposure to a magnetic field may trigger pacing at a magnet rate, like when from magnetic gate circuit. Very rare, there is a dysfunction called a runaway pacemaker, which is some sort of dysfunction in the primary circuit, which may lead to pacing at a very high rate, ventricular tachycardia, or it may be of very low amplitude that causes SSG. Okay. So this was a patient with complete AV block. This is actually a very difficult question also. We programmed the lower rate interval at 60 beats per minute, and when we evaluated the atrial rate, we noticed this. There is atrial pacing at this low rate. The explanation for this is BVCs may lead to this finding if the rate histogram. When BVCs occur, resetting of the VA interval. So atrial pacing here rate is about 4. However, actually the lower rate is still the same, not changed. And here are some of the observations that may be noticed during BVC patient with pacemaker. Like this example, atrial pacing at a rate lower than the lower rate limit during the rate histogram. Non-tracking of the P waves, as some of the P waves occur in the post BVC BVAR. Ventricular safety pacing when atrial pacing occurs accidentally with BVCs. Also, BMT may be initiated with BVCs. So this may be important when you notice in rate histogram there is atrial pacing lower than the lower rate interval, to search for BVCs, either in the ECGs or during interrogation. There is an algorithm called the ADIR-DDDR algorithm, which is like midget ventricular pacing of Medtronic. Actually, this algorithm changes from ADI to DDD in 3 situations. First, when AV block occurs in 2 consecutive beats, or when a very long ventricular pulse is detected. This explains this interrogation of a patient implanted dual pacemaker. Type, we notice here A pacing, V sensing, A pacing, V sensing, but at a very long PR interval. So this automatically switches to DDD mode. Here is another situation. Pacing, V sensing, atrial pacing, but no V sensing. So the device considers this ventricular undersensing as beat. And when it occurs twice, atrial sensing V basing occurs due to a mode switch to DDT. So we have those final two cases which are very interesting. Actually, this was a male patient who had implanted a dual pacemaker and presented for follow-up, and there is his ECG. 2 seconds to evaluate this ECG. Okay. Then here's the interrogation. Can anyone answer this question? Is there a problem in sensing or a problem in capture in the atrial lead? We want a full comment on the function of the atrial lead and full comment on the function of the ventricular lead.
Here you have to use what the pacemaker sees, and you have to look at the marker channel. This is most probably this is St. Jude or Biotronic?
St. Jude. This is actually St. Jude.
Okay. Okay. So if we look with you, Sasi,
Okay.
the first beat is atrial electrogram, and then ventricular electrogram, paced rhythm, and is sensed in the atrial chamber. But because it is in the refractory period, so it is atrial sensing in the refractory period. This is the far field ventricle sensed in the atrial chamber and is marked as refractory. Okay?
تمام. Okay.
كمل بقى معنا. So
Okay.
next beat is the same. Third beat is the same.
Actually,
Then we got,
with
yes. Then we got a PVC. This PVC actually has a retrograde P wave. And this retrograde P wave is again in the refractory period, post-ventricular atrial refractory period. So this is perfect. Then comes atrial pacing, because this atrial refractory will not set the lower rate. The lower rate is not set here. So the atrial pacing, this atrial pacing is not followed by an atrial electrogram. So this is mal capture, or the threshold need to be increased from this paced beat in the atrium, which is not followed by an atrial electrogram. Look at the atrial channel. Look at this spike is not followed by atrium electrogram, but this is ventricular paced. But is this real ventricular paced? No, this is only a spike. And I think this is a QRS complex because it is a native one. If you look down, there is the ventricular electrogram down. صح؟ لا لتحت ولا دي سبايك؟ لا اللي قبليه لا قبلها.
ده سبايك ده هنا
Okay.
في
So firing spike in the ventricle not followed by capture. So
exactly.
What is the next beat?
Then the next beat, actually there is here a small P wave,
okay,
which is not sensed as it occurs in the postventricular atrial planking period.
Okay.
And here a ventricular sensing and also atrial sensing as a junctional beat.
Okay.
Okay.
Yes.
So actually the sensing of the ventricular channel is okay. But there is a failure of capture here in the ventricular channel.
And in the atrial channel?
And in the atrial channel also.
Failure of capture.
Is oversensing far field and the sensing of the R wave. Also, there is failure of atrial capture.
Yeah.
This was actually at syndrome who needed to reposition
syndrome
both.
Syndrome? This is not a syndrome. Syndrome air. So we have to reprogram. We have to increase the amplitude of the atrial lead, of the atrial channel, and increase the amplitude of the ventricular channel because it was intermittent functioning. Sometimes it captures, sometimes it does not capture. So we have to measure the threshold thoroughly, and you have to have the programmer in order to solve this problem. Don't tell the patient you need to change the leads, you need to change the battery. No. if you can solve any problem with programming, it is better than opening a patient, causing infection, not able to take the lead out, or insert more leads, doing more problems and going to complications. اللي بعده.
This is
What
a
do you say?
final case, and it is a very interesting case. This was a 55-year-old female patient who
شريف
had
حبيبي.
بالظبط recurrent dizziness with exertion, 2 ECGs from before implantation. Just examine the rhythm very close. After implantation, this is the ECG. And all we went for programming, and we tested the atrial sensing and the atrial capture and ventricular sensing and ventricular capture and impedance of both the leads. Excellent. What can we appreciate in this ECG, and how to solve this problem? And is it a
Dr. Hammam,
This is a very tough question.
I know we could not solve this problem easily.
First ECG, please.
First ECG, okay.
This is before implantation, and a lady who is having dizziness, and this is her ECG. What is the diagnosis of this ECG? Because this is the clue for the pacemaker ECG. This is before implantation. What is this, Hammam?
It looks like SMOPS 2.
No,
BB.
no.
I
You see red P wave?
I can do more, okay?
هو طبعا quality is not good. But no.
Not good.
Okay. Do you see any P wave?
Look in lead 2.
No B wave.
Actually, there is a P wave, but it is
It's slow
within
ether.
just before the QRS complex. شوف اعمل ماركر عليها استاذي.
Okay. This is
اتكبرها
P
تاني.
wave.
زوم ان لو سمحت.
Okay. حلو حاضر.
اهو.
هي
اوكي.
ماشي وهي.
طب اهي.
أكبرها تاني. Can you see this hand?
Yeah.
Yes. Here is the P wave. Here's the P wave.
So this is the junctional rhythm. The patient had sinus bradycardia and accelerated junctional rhythm as an escape rhythm at 47 beats per minute. Look at here is the heart rate up. So for this, she received dual chamber pacemaker. Show us the next ECG before implantation, ya Arsasi.
Other ECG, you can note it here that
Yes, this is
sinus.
This is some conducted beats, and this is why there is like a pause or a distance longer than the previous one. And this is junctional escape again. And then the sinus beat may be conducted to this beat. And here is a junctional escape because this is never a P wave, PR interval. And then the next beat is conducted. And then what you see after the T is the U wave. Show him the U wave. Yeah, this is a U wave. Yep. This is not a P wave. Okay. So this patient has sinus bradycardia and junctional escape rhythm. So she has sinus, no disease. Show us the ECG of the pacemaker, Stasi.
I'll zoom in.
Yeah. What happens here is that the atrial chamber started to fire spike and followed by a P wave. But the junctional escape rhythm is faster than the lower rate of pacing, which is 60. So it looks like there is P wave and QRS complex simultaneous. How come? Because the junctional rhythm is faster than the lower rate. So that was the case of Sharif Habiba.
Yes.
He tested the atrial lead alone. He tested the ventricular lead alone. he tested sensitivity. Everything was perfect. So how we solve this problem? We made the lower rate to 70 to overcome the junctional escape rhythm to preserve the AV synchrony of the patient. Do you have the ECG after correction?
No, unfortunately.
Yeah.
But
Okay.
we can notice here that here's a ventricular safety pacing also. Ventricular safety pacing here and atrial
Yeah.
pacing here. Here, no atrial pacing as this is considered as a BVC. The junction
Mazboot.
is considered
Yeah.
as a BVC, which resets
Yes.
timing. Here may be conducted atrial pacing
Yes.
and resensing.
Yes. Yes. So the solution was to increase the lower rate of this pacemaker in order to overcome the escape junctional rhythm, because the patient needs the atrial kick and we need the synchrony between the atrium and the ventricle. And she was conducting. So the problem was the bradycardia of the sinus node and the junctional escape, which is faster than the lower rate of pacing. Thank you very much, Sasi.
Thank you, Dr. Mervet. Thank you very much.
Excellent explanations.